Yeah, welcome to everybody who is joining us. Thank you. And also, I'd like to welcome our two brilliant speakers today who are joining me. Darren Woodward, who's Director of Therapy Services at Rightsteps, and Professor Myra Hunter, Emeritus Professor of Clinical Health Psychology at the Institute of Psychiatry, Psychology and Neuroscience at King's College London, and lots more besides. So actually, I will ask both of you to introduce yourselves a little bit more when you come to speak, if that's all right. So just to let you know that the webinar, we are recording it today. Everybody has a chance to make comments and ask questions. Please use the chat function for that, please. And we will get to those when everybody's finished, if that's all right. And as I say, without further ado, let me sort of start. So for those of you who don't know Wellbeing of Women, we're a women's health charity, and we save and change the lives of women, girls, and babies. And we do this through research, education, and advocacy. And our research is very interesting. Actually, we have over the years worked with Professor Hunter, and I'm sure that she will mention a little bit about that. And in fact, we are doing some research at the moment, of which Professor Hunter is involved. So that's very exciting. But as we all know, women make a really important, vital, valuable contribution to the workplace every day. Nearly half of the working population in the UK is women, and those aged over 50 are the fastest growing workplace demographic. And women just are so important. And a figure I learned yesterday, and I'll have to read it from my phone actually, so please forgive me for doing that. But I was at a round table yesterday and heard that something like 150,000 women have been lost from the workplace. And that's just since COVID. And that's all to do with the menopause. So anything that we can do to support women, to help them manage their symptoms at work is incredibly important to us. And it's actually why we launched the Menopause Workplace Pledge with the support of Hello Magazine and also Bupa in 2021. We've got nearly 3,000 organisations signed up. And I saw this morning that several more are going to join us as they've emailed. But it's really important that we do this, because we found through our own research and through focus groups that women struggle so much with their symptoms at work, and it's not just physical, but it's the emotional symptoms as well. So we know that obviously every woman will go through the menopause. 1 in 4 don't seem to have many symptoms at all. At least half of women do have some symptoms, but they are able to manage them. And then we do know that 1 in 4 really struggle. And those symptoms range from everything from anxiety, loss of confidence, low mood, insomnia, night sweats, joint aches, hot flushes, poor sleep. And we do know that good support really helps women in the workplace. It means that they don't have to reduce their hours, they don't have to pass up promotions, and in some cases it will mean that they don't have to leave their jobs. So we're thrilled that so many of you have signed the Menopause Workplace Pledge, and we hope you'll continue. So our webinar today is looking at the role of Cognitive Behavioural Therapy, or CBT, and I'm delighted that we've got two fabulous experts who are going to talk us through this, what it is, how it works, and how you can use it. And I think it's particularly important as we come to the end of Menopause Awareness Month, which also included World Mental Health Day on the 10th of October. So I am now going to hand over to Darren Woodward, who please do introduce yourself, Darren. And I'm thrilled that you've got the task of actually explaining what CBT is. So over to you.
Thanks, Janet. I'll see if I can just share my screen. Does that look good to you, Myra?
That's great.
That's great, lovely. So sorry about the technical start there. Thank you, Janet, for the brief introduction. It's a pleasure to be able to present to you today. My name is Darren Woodward, and I'm the Director of Therapy Services at Rightsteps, which is part of the national charity and social enterprise Turning Point. I'm a fully qualified psychotherapist and an executive coach. I've got about 5 minutes or so to talk to you about the challenges of mental health within midlife, and as Janet mentioned, a bit of an outline about CBT and what CBT is. So midlife, which is a period between 40 and 60, presents a unique set of mental health challenges. It's a complex and transformative phase of life. Many people can navigate this period of life successfully. However, it can be a time of increased vulnerability and stress for others. Often we focus on the mental health challenges of adolescents or people in old age. However, according to a longitudinal study in UCL in 2021 with almost 30,000 people, approximately 1 in 5 people born in the 60s and 70s believe that they experienced the greatest amount of psychological distress in this part of their life. Midlife can usually be the peak in someone's career. People have acquired increased responsibility, both in terms of work and at home. Many people in midlife are settled in their careers and established in their profession. However, career stagnation, job loss, job insecurity, or financial setbacks are common. Parents may become grandparents. A frenetic home may become a quieter place. Questions about identity and purpose can pose a significant challenge to people in midlife. It can be a time for people to reflect on their accomplishments and provoke feelings of existential angst, and this can lead to feelings of dissatisfaction and a search for meaning. This can also spark feelings of anxiety and depression. People's bodies change consistently throughout their lives. However, midlife can be a time when, often for the first time, one finds oneself unable to complete a familiar task, or they may need to complete it more slowly. Some people retain a level of fitness throughout midlife, but for many, fitness levels are reduced, weight and BMI are increased, and this may be due to limitations in time, due to work or family commitments, but it also may relate to ill health. During midlife, it's more common for people to acquire a significant illness or injury, or have friends or family members that become very unwell. And this in itself can evoke heightened awareness of one's health and mortality. And people cope differently to significant illness and the confrontation of their mortality. Some people can be in denial about it. I'm never going to be ill, or if I'm not ill when they really should be in bed and wrapped up. Or people may struggle to talk about illness or death when they are extremely ill. Other people can be extremely anxious about the possibility of becoming ill or dying. This in itself can be disabling and limiting. It can affect what people do, where they go, or decide not to go due to fears of increasing the likelihood of becoming ill. People can ruminate about minor symptoms of illness and catastrophize the situation, thinking that everything's the worst case scenario. People in midlife are carers in the main. They may have aging parents, children to look after, young adults that need their support. The strains, pressures of being a carer can be immense. This can be intensified by the other factors that I've mentioned earlier. Social circles can change over time, but strong friendships are vitally important for mental health. Good friends can help you through the tough times and be with you to enjoy the good times. As children grow up and leave their family home, people in midlife often consider downsizing to realise the capital in their property and manage their expenses. As retirement approaches and income levels drop, this can often be a necessity. This decision can be a very big one, as it has an impact for many years to come. The familiarity of the place, but more importantly, friends, are an anchor for good mental health and well-being. I have skipped through briefly a litany of issues that can contribute to mental health challenges in midlife. Therapy is an effective tool in supporting people with a wide range of these issues, including existential anxiety, health anxiety, or coping with a wide range of emotions and issues relating to serious illness. So, cognitive behavioural therapy, or CBT as it's commonly used, is an evidence-based type of therapy. CBT is defined by the BABCP, which is the professional body for many CBT therapists, as so cognitive behavioural therapies, or CBT, are a range of talking therapies based upon the theory that thoughts, feelings, what we do, and how our body feels are all connected. If we change one of these, we can alter the others. Our thoughts control our moods, emotions, and our actions. If we change the way that we think, we change the way that we act and react. When people feel worried or distressed, we often fall into patterns of thinking and responding which can worsen how we feel. CBT works to help us notice and change problematic thinking styles or behaviour patterns so we can feel better. CBT has lots of strategies that can help you in the here and now. This collaborative therapy uses specific evidence-based treatment pathways to address particular conditions and issues. This is like a menu of interventions to choose from. CBT is different from counselling. Counselling looks to the client to set the agenda of what's discussed, and the positive therapeutic relationship between client and therapist will explore them. With CBT, the therapist takes a more proactive role in addressing the presenting problem using the evidence-based treatment pathways. CBT recognises that it's not events that produce bad feelings, but the way these events are appraised. One event may lead to a range of emotions according to how that event is interpreted and evaluated. The central aim of much cognitive behavioural work is to replace beliefs that contribute to self-defeating behaviour with beliefs that are associated with self-acceptance and constructive problem solving. There is always an assessment prior to a psychotherapeutic treatment, and there are mainly two types of CBT. So the first one is low intensity. This is a useful tool in supporting people with mild to moderate anxiety and depression, and it can be useful in supporting people with sleep problems, generalized stress, the first instance of health anxiety, and low level OCD, obsessive compulsive disorder, or panic. This usually involves up to 6 sessions, each of which is about 30 minutes. High intensity is used for more generalized anxiety and depression, or recurrent depression. It's also used for social anxiety, post-traumatic stress disorder, PTSD, health anxiety, or more severe OCD or panic disorder. This is delivered by a more qualified and experienced CBT therapist or psychologist. The number of sessions required can vary depending on the presenting condition, but anything from 8 to 20 plus. 50 or 60-minute sessions is about what's normal. So there's a huge amount of support out there by your employer, through your GP and the NHS, or paying for it privately. So don't suffer alone. Take the hardest step, which is the first step, if you feel that you need it. And thank you. I'll try and stop sharing now.
Thanks so much, Darren. That's very helpful. Myra, I'd love you to come in now. And one thing that struck me was a story that I've heard you talk about when you've been doing other presentations like this. So it'd be interesting if you'll use that today about how people think and their different thought processes, and your example of walking, you walking somewhere and somebody you knew walking the other way. So, and I think that really brings it to life, which I think is so important for everybody on the on this webinar today. Anyway, please take the stand, and over to you. Okay.
Thank you. It's my pleasure to be invited today to talk about this. And I think it's really nice to be able to bring together what we know about the workplace with an individual therapy, because the message I'm going to be giving is we need to tackle both levels of the environment at work, but also the individual. You know, usually it's either or, but I think in the work we're doing, we want to, and the research suggests that both's needed in order to improve the quality of women's working lives. So I will bring that example in, but I just want to say a little bit, skip through what is menopause, and then a little bit about mental health and work, and then talk about the CBT. So we've heard quite a bit about midlife, and I think the menopause is literally a woman's last menstrual period, and it's preceded by a few years of irregular menstruation, sometimes heavy menstruation, and also often the beginning of symptoms, the hot flushes particularly, and sleep problems. So, you know, this diagram is really based on research over many years, and I think rather than purely viewing the menopause as a biological hormonal change, which it is, but it's also very much affected by a woman's experience at work and anywhere, is affected by psychological factors and social factors as well. And we've just heard about attitudes, and I think these are really important. We hear about social stigma about menopause, ageism, sexism, which can subtly creep into places without people realizing it's happening. And also the social, you know, really practical things that Darren's mentioning about social factors that are independent but can interact with a woman's experience, life stresses, relationships, you know, demands accumulate over time, don't they? But also, on the other hand, the importance of social support. So we do live in a culture where, you know, youth and beauty are valued over age and wisdom quite often. And as you were saying in the introduction, you know, women are often at their peak of their careers when they're going through the menopause, and, you know, very knowledgeable and a very huge assets to the workplace. An important factor about the menopause is how much it varies between women. And I think some of these factors explain the variation, because if you look at all these different factors that affect a woman's experience, psychological and physical, you can see how different we all are really, and how these factors can contribute to the variation. And, you know, these changes are happening. We don't reach the menopause, you know, naively. We've got lots going on in our lives. So it occurs in the context of age changes and midlife, when there's increased pressures, as we've heard. But also there's a lot of variation between cultures. In some cultures it's perceived very differently, and symptoms are perceived differently, different cohorts and different generations. So all the research that we've been doing really needs to be repeated with each generation going through, and particularly this generation, who are much more vocal about it with social media, are having a different experience to, you know, my generation that didn't have that. So just want to skip through menopause and mental health, because just to really look at what we know and what we don't know, actually. We've heard about the symptoms. The main symptoms are the hot flushes and night sweats that are specific to the menopause. They have knock-on effects to sleep problems, and women report low mood and anxiety, cognitive difficulties, and associated mainly with this menopause transition. So although it's an event, it's actually a transition over several years that can happen. And hot flushes and night sweats are associated with general distress and anxiety before and after. And I think a key message I want to give is that there's bi-directional relationships, two-way relationships. hot flushes can cause mood problems, and mood problems can cause hot flushes. So, you know, it's quite hard to study, and when you're intervening in this area to help women, you can often get caught up in a dichotomy between, you know, is it hormones, is it hot flushes, or is it me, is it my mood? But actually, I found the most helpful way of approaching this is looking at these as interactions. They both affect each other, so we tackle them in the best way we can for women. Obviously, existing health issues and other psychological problems can be exacerbated by the menopause, thinking of it as just an extra stressor on the woman, physically and emotionally. Now, looking at the evidence, and sometimes the research just hasn't been done enough, but the evidence we do have is there is evidence of an increase in depressive symptoms for about 9 to 10% of women. So that's saying an increase. However, as you were saying in the introduction, you know, we've had COVID, we've got you know, a lot of people have financial difficulties at the moment. There's the base rate of distress and depression have increased over the last few years. So that's 10% on top of this additional, you know, distress and mental health problems that people are having. For major depression, you know, clinical depression, it's less common, and it mainly happens for people who've already at risk, who've had previous clinical depression in the past. Many women do report anxiety symptoms, but there's no conclusive evidence that, you know, the psychiatric disorders such as bipolar disorder, psychosis, or suicide increase actually at the menopause. Nevertheless, you know, quality of life can certainly be affected by combinations of these factors. So, moving on to menopause in the workplace, and as you were saying, Janet, we've done studies looking at this in detail, and you know, do ask me more questions in the Q&A if you want to know more about any of this. So women do report that hot flushes are particularly problematic at work, are hard to deal with due to discomfort and social embarrassment. So the social embarrassment is where we think that, you know, what everyone's thinking about us. People think that the hot flush kind of discloses something quite personal about them, their age and their stage, reproductive stage, and it feels embarrassing. Women often mind read their colleagues, imagining that they are thinking negative things about them, and in some cases they do, but, you know, women often avoid situations and suffer in silence, don't ask for support because of the embarrassment around this. Night sweats can lead to daytime tiredness and impact quality of life. And we've heard that so work environments, both physical, you know, having open windows, you know, the temperature, having facilities, and the interpersonal, you know, what woman feels her colleagues supportive or not, can impact on women's experience of menopausal symptoms. And again, as has been suggested by previous speakers, that, you know, the midlife period, women do report more work stress than men or women of younger ages. So Wellbeing of Women are doing this, encouraging organisations being encouraged to offer guidance and policies on menopause and to offer support as needed. And I think there's lots of work going on in these areas that many organisations are now providing guidance and support. But what we're going to move on to looking at how you might provide individual support and what women can actually do in the workplace. So we've developed, I mean, my research teams over the years, I mean, it takes many years to develop these things based on research, look at a specific cognitive behavioural therapy approach for hot flushes and night sweats, otherwise called vasomotor symptoms. So we're looking at the relationship between physical symptoms, thoughts, feelings, and behaviours. And so I can give you this example. Well, let me give you this example now then. So a little bit of imagination. So if you imagine you're walking down the street and you see someone across the road who you know, an acquaintance that you see every now and again, but they walk straight past and ignore you. what might you feel and think? So we can't ask you all to do that, but if you just are aware how you might feel. So we would, and I'm going to have the parallel here with my diagram where I'm thinking this represents the experience of a woman in an office going through the menopause, sweating with the physical symptoms, the sweating, the palpitations, the red face. And she's in an office with younger men and women. So I'm asking her what she might feel like. So when if you relate to your example, so some of you might think, oh, she looks quite busy. She's probably thinking about what she's been doing in the work today. And she's just a bit distracted and carry on walking. She'd feel okay. And she'd go home and say to somebody, oh, I saw so-and-so in the street. She looked quite busy. But some of you might be thinking, oh, why did she not look at me? If I offended her, if I'd done something wrong, and feel, self-critical about that and feel a bit miserable and a bit rejected. And some of you might think, oh, how rude, and get really angry and upset about it and think, oh, I'm not going to contact that person again. So you can see how the way they interpret that situation, which was the same for everyone, can lead you to having quite different responses. So taking that example to our woman who's in the office with these young people, she's sweating, having palpitations, having a red face, and we ask her how she's feeling, and she might say, maybe not all these things, but she might say, I feel embarrassed, anxious, out of control. And then I'd ask her, well, if you're feeling like that in that situation, what might be going through your mind? What might you be thinking? And so I put a range of these things here, which link to different feelings and different behaviours, perhaps. But a common one, in our research, there are two main sorts of thoughts that people have about hot flushes. And one is, everyone's looking at me. It's that's a social anxiety one. They'll think I'm stupid, old, whatever. And if you actually verbalize these things, they actually don't. It's easier to challenge them. If you keep them to yourself, you can just experience the feeling. But we would explore that with her and challenge it, really. Another one is to think, oh, I can't cope, is feeling out of control, that you don't have the coping strategies to deal with the situation, and they're just going to get worse and worse. And that can lead to feeling frustrated and depressed about it. And a common behavior would be to often avoid situations. We've had people sort of covering their faces like this, which actually attracts attention to you, even though you're trying to avoid it. It has the wrong effect often. Or they might stop doing, leave a meeting or not come to work the next day or something like that if they found it had a very difficult situation. So the CBT really targets the thoughts and the behaviours. And similarly, in our research, we found that younger people tend to have more generally negative beliefs about the menopause. However, when we did a study asking, because these women were thinking in our group CBT, they were thinking that their colleagues were thinking all these negative things, and we were thinking, well, how can we challenge this? So we did a study where we asked 45 to 50-year-olds, 25 to 45 men and women in several workplaces, if they were sitting near a woman who was going red or sweating, what would they think? What would they feel? We didn't mention menopause or hot flushes or anything. Now, actually, a lot of them didn't identify them as menopausal symptoms anyway. Some of them said, oh, maybe she had a cold, or she's run upstairs or something like that, or she'd been to the gym. And they were very neutral about it. And people say, oh, I hope she's okay, but they weren't thinking or reacting in the negative way that the women in the group thought they might be. So we use that as evidence against to challenge these sorts of negative thoughts. And these negative thoughts come from, the cultural, social beliefs about older women, don't they? Right, I'm taking time here, so skip through. So moving on to the evidence. So there's evidence generally that CBT is an effective treatment for anxiety and depression and sleep problems across the age range. NICE Guidance 2015, on the basis of our work, the anxiety and depression part of the studies showed that it was effective during menopause. And there's often strong interactions between hot flushes, night sweats, mood and sleep. So often people seek help and feel overwhelmed when these three areas are interacting together. And for this reason, we developed the CBT for hot flushes, also including CBT for stress and CBT for sleep problems. And we've shown now in 6 clinical trials with over 1,000 women that it's effective. And this is a summary research paper that describes these results. And the CBT is currently being re-looked at by NICE for whether it's, they can approve it for the treatment of hot flushes and night sweats currently. We should hear soon. Now, the CBT can be delivered in groups and using self-help booklet, and we've published a book about this. But for this study, Menopause at Work, this was the first study that we did using a self-help booklet with no clinical involvement at all, because in the workplace, you're not going to have psychologists on hand necessarily. So we used the self-help book CBT booklet that had these different elements in it. And again, I mean, if somebody asks me in the Q&A the details of the CBT, I'll describe that a bit more then. This was with 8 organisations for working women who had problematic hot flushes and night sweats. And they had the booklet and they used this over, it was like 4 sessions over a month. And we had significant improvements in problematic hot flushes, in sleep, well-being, and work and social adjustment. And in this study, we also measured some work outcomes. We measured absence, we measured subjective performance and presenteeism. The absence was there wasn't much absence actually in the study during that time frame. But the presenteeism significantly improved. And in this, it's defined differently in different studies, but what it means here is that women had symptoms, but were able to manage them more effectively at work, so it didn't interfere with their work. The second study we did was an evaluation. We developed an online training for employers and managers to try and increase their knowledge, attitudes, and confidence in talking about menopause at work. So you can't do anything without actually being able to talk about it. And many managers were actually, unfamiliar, found it difficult to talk about. So we had some videos with actors, being a woman and being a manager, and some videos were helpful and some were less helpful. So we developed some do's and don'ts about how to manage these situations. So on this slide, I've just got the different ways that we are implementing the work. And we've got the self-help book is published with Routledge, and the Living Well book describes the CBT too. We've got a manual for group CBT that psychologists and counsellors can run the groups themselves. And we've actually done some training with Darren's staff to help them, to enable them to use the CBT during COVID online. We've got training for health professionals in group CBT run with the British Menopause Society and fact sheets on their websites. And I've been working with Rightsteps for a couple of years now, and helped them to develop an online CBT, and which can be supported by their psychologists and counsellors. And currently, the previous study was kindly supported by funded by Wellbeing of Women, who've been very supportive across this whole body of research, really. And we're currently working on implementing a Meno kit, which is like a toolkit, including information for women, some tips, CBT tips, and training for managers. So we're looking at the individual and the environment in this Meno kit, and we're looking at this to see how well it can be implemented, because I think that's the stage, how it's quite a complex in large organizations, how you actually make this happen. We can give one a talk now and again, but actually to infiltrate all the layers of the environment of the organization is quite complex. So we're in the middle of this study, and we should be reporting on this towards the end of next year. So I think hopefully I've shown that CBT is an effective non-medical option, and that's what it's there for. It's for women who don't want to or can't take HRT and want an alternative. and it can be delivered in a range of modes. But I do think, again, I think improving women's experience of menopause at work requires change at that environmental and the individual level. Thank you.
Thank you so much, Myra. We've had some really interesting questions. So I have posted in the chat links to the directory of chartered psychologists, the British Psychological Society, some of whom specialise in CBT, not all. And there is a register of accredited therapists in the UK on the British Association for Behavioural and Cognitive Psychotherapies website. All of this is you can find on the NHS website first and foremost. But I think the question started about sort of accessing, and I think sort of Katie mentioned this first of all, and then Catherine. So I don't know, Darren or Myra, who really wants to answer this one, but I think it's when people are in the sort of depths of feeling so anxious that they're struggling to find resources. Is there anything you can say that sort of can help people? Because as we know, the NHS is overwhelmed. It is difficult, but as I understand it, the talking therapies that they offer, everybody should be able to access, even if it's just for, as you say, the sort of 4, 5, 6 sessions. So sorry, I'll stop talking. You answer, please.
Yeah, I saw those come through, and the Turning Point, the company that Rightsteps is part of, has got a couple of talking therapy services commissioned by the NHS. We kind of know the challenges of access. It can be pretty quick to get an assessment, maybe a couple of weeks, and then can sometimes take a couple of months to wait for therapy, which is predominantly the low intensity CBT. I think, as someone referenced within the chat, that they experience that, usually up to 6 sessions. And that can sometimes be enough. Accessing that, you can go onto, type in talking therapies, and you'll find a referral link that you can send yourself. And if you need to re-refer yourself after a treatment session, you can do that. It's also worth thinking that many employers have got an employee assist program, again, which is free of charge, that the employer pays for. Some offer CBT, many don't. But it's worth having a look and asking. And I think your guidance about the BPS and the BCP guides are very good. What Rightsteps does, which kind of works with employers directly to kind of augment kind of EAPs, is to kind of provide some of that more bespoke treatment through psychologists and other therapists for this type of thing. Like Myra referenced the kind of work that we've done together to do training on the great work and evidence base that Myra had undertaken on hot flushes and night sweats. So getting the booklet in and getting therapists trained on that bespoke type of therapy is really important. But also, in addition to that, as Myra referenced, there are people present with different issues like anxiety and low mood, and being able to tailor the treatment to kind of fit with that is really important. And just finally, I know this is about accessing to therapy, but there was a question about the online therapy, how effective is that? But generally, the kind of blended therapy using online therapy, online CBT, preferably if it's kind of guided through a therapist, is as effective as the therapy delivered directly. That's just generally in terms of the research. But being able to deliver kind of asynchronous, so on an online platform as well as therapy, is something that lots of providers, including us, are exploring. So for us, the Rightsteps is a kind of employer business to business, but we also have something called Live Life, which has the same therapists and psychologists, the same training if people want to pay for it privately. There are lots out there, just we're just one of many.
Just so that I'm clear, Darren, I think you said that you offer some of talking to therapists via the NHS.
Yeah.
Yeah, so that's free.
Yeah, talking therapy is
Yeah.
always free.
Yeah.
It's just commissioned by different people, and
Yeah.
by the NHS, there's 200 or so of those.
Okay, that's really helpful to know, so that for organisations that perhaps aren't providing support and don't intend to, then there are options. I hear what people are saying. They might have to wait, and they're a long time, and that's not helpful when you're feeling anxious and low and struggling to work. And we often talk about menopause affecting women in the prime of life, and that is so important. But I also always feel that it affects all women in the prime of life, whatever level they are at. And if you're unable to work and you're the primary income bringer to the family, then that's a real struggle. So the more we can do for women in the workplace, the better. And it was very depressing to read one of the comments in the chat about saying that somebody's talked to their colleagues and managers, and there's been smirking, and they don't feel that they're being heard, and they feel that perhaps their manager thinks they're making excuses. They call hot flushes power surges. Great. I think in this situation, you should probably go and talk to somebody else. If your manager is not being empathetic and listening and kind, then you should go to somebody else, like somebody in HR, or somebody you feel who might champion this. I mean, many workplaces are getting better, but it is not perfect. So we hear what you're saying, and it is very hard. Diane Rayner has said, how does CBT help night sweats as they are coming through your bloodstream and hormones? Sure. Who wants to take that?
I can. I mean, just to say, I'll come back to that. I think in terms of the previous question, I think there's a lot of power too in women if they're individually finding, being stereotyped negatively, to actually talk to other women and get the support and have, get a few women together and develop a support group that can have a stronger voice in their workplace. Because I think talking to other women is really helpful, and we shouldn't. And I think it's also, that point of starting to talk about the menopause at work. I think the important thing is that the first attempt to talk about it is done well, and in our training of the managers, we were really all we were asking them to do is to use good communication skills, but to emphasize that with the examples, and to listen, to not make assumptions. Women didn't want to be treated, this is from a research study I'm saying this, that they wanted the managers to have some knowledge of the menopause, but to ask them about their experience, acknowledging that it's varied, and not to make assumptions and say, oh, my wife had this, so you've got that. It's very varied. And then to ask the woman what she might want, but to do that in a sensitive, caring way, and not to be embarrassed themselves. Okay, and just, I'll come to the night sweats, but looking at the list of queries here on the chat, there is the self-help book is available, and that's got everything in it, the 4 sessions, so that's the quickest, easiest way to actually access it. But I do agree that it needs to be surrounded by enabling, and it needs to be suggested in a way that's positive and supportive. With regards to the night sweats, we help people to go back to sleep. I mean, I think with the hot flushes in the day, you can temper them with a calm breathing exercise and with calm thoughts, and actually challenge the negative beliefs and everything else, and to look at reducing stress. But I can obviously, night sweats are harder because they just come onto you and wake you up, don't they? But what we aim to do there is to help people to use strategies to stay calm, do something automatic without sort of having to wake up too much, and then use CBT to help them to get back to sleep again. And usually, if stress in the day comes out at night, doesn't it, when you've got less rational mind to deal with it, and often dealing with the daytime stresses and getting some exercise into the week, doing activities that help enable sleep also help to calm night sweats.
Yeah, I'm just literally going through. Somebody's put in here that good tips for before bed to help sleep can be eating a kiwi fruit, banana, or lettuce sandwich. I tried banana last night, fell asleep well, but woke very early. I think coming back to your point, Myra, which is getting together in the workplace with other women, if you can, because some, small, medium businesses might not have the large range of colleagues that you need. But if you can, I think absolutely, Myra, agree with you, get together and you can try and take things forward. But we also find that when women get together and share tips, that's a really great way of learning new things. And I think we've all found that actually it in a way, it doesn't really matter what it is that works for you, as long as it works for you. So do try things. I mean, there are quite a lot of organizations out there making so-called menopause products and things. So do be careful on those, because you don't need to spend money. But I would strongly recommend joining menopause forums and networks, because there is a huge amount of information out there, and it is a way of learning different things. Somebody's asked about a talking therapy service in Scotland, so we'll find you a link for that, because I'm absolutely confident that there is one as well. Somebody's talked about menopause symptoms and going to the loo frequently, and that is definitely there is a link there. So you are right. That's sort of definitely helps. Somebody's commented on saying, is there value in CBT practitioners being menopause specialists, or are the general principles of CBT suitable to any situation? I better leave that to our experts.
Not necessarily. It's helpful to know them, to know about them. In the manual we've got for the groups, there's a few chapters about menopause, and I think that's you need to understand. But you don't have to be a menopause expert necessarily. I think.
No.
Someone also asked, is CBT effective in online? Yes. Yeah.
Very much so, and apologies for sending I post a link for the England and Wales talking therapies. I know that that Scotland, the gatekeeping is through the GP. I know that's the kind of single source of referral, but there is a link, and I'll see if I can find it and post it in here.
There's a comment from Sue saying she works in a male office. 92% of her colleagues are male, so and she's the only female in the sort of menopause age range. So it's difficult, and she is her own support group. And Sue, I hear that. I do know that the Department of Work and Pensions are looking at allyship going forward. So we need to keep up to date on that. And in fact, I'm talking to the women's health champion there, Helen Tomlinson, and it is something that they are trying to develop, is some kind of forum allyship, so that people like you, Sue, can get together with others in similar situation, and also there's best practice and learning. So we'll definitely keep you posted on that. So that's great. And I think having men in on the conversation. So it's great, Darren, that you're here today. And I don't know how many men we've got on this call. It would be great to know if we have. But it's coming through loud and clear. Sorry, Myra, you wanted to say something?
Just on that score, and I'm thinking about how you might join in with the men. I mean, men can have hot flushes as well, and we've been on a second study with men who've had prostate cancer treatment, and because their androgen levels are reduced as part of the treatment, they have, in quotes, menopausal symptoms, hot flushes and night sweats. And we're using the CBT for them, and just finishing a study with colleagues in Southampton, and that's been done in groups and certainly in self-help, and so it works for them. So that could be an opening, you know, it's not just a woman's thing, actually.
Absolutely, yeah. No, I think that's very true. A couple of people have asked if you would be able to share some of your slides, Myra. I don't know if that's possible.
Yes, of course. I mean, I was thinking that, I mean, the link, why don't I can do that. And
if you,
the link is, you know, you can just link on there and you get Women's Health Concern, which has got really a summary of the CBT, and that's what people, that's a kind of introduction, which often isn't good enough. It's got some tips, and it gives links to the book.
We will what we'll do is we'll send out a post webinar email anyway, and also link to the recording, and so we'll also link to your slides and to Women's Health Concern, which is a great source of information. As it's nearly 2 o'clock, I think we better stop now. I would like to say a huge thank you to Professor Myra Hunter and to Darren Woodward. Thank you so much for coming on today and talking to everybody. And obviously, I'd like to say a huge thank you to everybody for joining us. We couldn't do this without you. And please do go on to the Wellbeing of Women website, join us, and support everybody when it comes to women's health. And if you can make a donation, please do. That's how we survive, through public donations. So we'd be very grateful for them. But thank you very much to everybody. And we'll see you again next time for our next webinar. Okay, thanks. Bye.
Thank you. Bye.